So it's nice to be with you here today, and I have to say, if you don't already appreciate how lucky you are to have an organization like Q Corp in your community, being led by a group of really committed and excellent staff and board members, I think you should appreciate that, because a lot of communities around the country that I go to don't have such an organization, and increasingly are saying to me, how do we get one of those? Because we really need to have somebody being able to do that. So what I'm going to do is talk about how I think, at least, and these are just my ideas, which you are welcome to disagree with, how Oregon can become a national leader, not just sort of following what everybody else is doing. If you don't agree with me at any point, you can use the scuba diving move, which is to go like this and hold your nose and tell me that you have a problem with what I'm saying. So anyway, I'm going to come down here so I can point a little bit at the slides. So useful to sort of start and say, so why is there all this interest in hospital readmissions? If you go back just a few years, this was not exactly front and center on the national agenda. And the answer is we started measuring them, which is one important indication as to what happens when you actually start to measure some quality issue in the community. You don't manage what you don't measure. You don't care about something that you don't actually know about. But it goes beyond that, because I think there is this huge interest nationally now in how we can actually reduce healthcare costs without taking something away from patients. And readmissions, most patients don't want to be readmitted, so it's a good thing for them. And because readmission rates are so high, when you're talking about 1 out of 4, 1 out of 5 people, significant savings opportunities if they can be reduced. They affect most kinds of patients, so it's something that we can do fairly broadly, and most payers are going to be interested in that. There have been some projects that have shown that we can make a significant impact on readmissions without much, with fairly low cost. And if you think about it, that's actually, and the savings can actually be achieved quickly, I should say, too, which is that you don't wait 5 or 10 years to be able to do this. And that list is actually probably a good set of criteria for things that we should be doing in the community more broadly. We should be measuring to try to identify opportunities for reducing costs without rationing, where there are significant savings opportunities that affect all payers, that can be achieved at low cost and can be done quickly. And readmissions is one example of that, but there are others that can be pursued as well. However, not all readmissions can be prevented, and we don't really have good measures to try to distinguish which ones can and can't. That's something that is still in process. There's a lot of different factors that can affect readmissions. There isn't somehow just one problem that you can easily tackle with one single intervention. Typically, you've got multiple providers involved, so this is a lot more challenging to be able to deal with than the just what do you do in your physician practice or hospital. And current healthcare payment systems don't actually support doing this in ways which I'll talk about in a few minutes. What's currently being done? Well, there's a lot of focus around the country now on transitions, and many people here are obviously doing transitions. Why is that? Because there's evidence that there's weaknesses in hospital discharge, because we know that there's a lack of coordination during transition. Many people have experienced that personally. Kaiser has actually done a lot of research showing that patients actually say, I'm not ready to hear my discharge instructions when I'm in the hospital. So you've got to be able to figure out how you're going to do that after they're discharged. But it is easy to identify the patients. They're being discharged from the hospital, easy to find them. And there have been several projects that have actually reduced readmissions fairly significantly through simple interventions focused on transitions. And so a lot of the interest evolved from the fact that there are several projects. The Transitional Care Project that Mary Naylor did, the Care Transitions Project that Eric Coleman did, Project RED in Massachusetts that Brian Jack did, all focused on how do you actually change the way the discharge and immediate transitional care process worked. And I'm not going to go through these in detail, but they've all been in the literature as having significant reductions in readmissions and replicable, not just in one site. So there's a lot of effort now to try to expand these things nationally. I think there's a bit of a competition now for who can come up with more acronyms. So there's Project Boost and others. There's the QIO program that was done in 14 communities around the country. And now in the Affordable Care Act, there is $500 million being invested in improving care transitions through the CMS Community-Based Care Transitions Program, although focused on Medicare. And one thing I would point out in all this is that most of these initiatives have been focusing on senior citizens and Medicare beneficiaries, even though the problem of readmissions goes much broader than that. If you conceptualize the problem the way a lot of people have been conceptualizing the problem, this seems like a logical thing to do. So we've got patient coming out of the hospital, going into the community, they're coming back to the hospital in 30 days, so it makes sense to do stuff here, to do stuff in the immediate post-discharge area and in this 30-day period, because that's what we're measuring. We're measuring 30-day readmissions. The problem is that readmissions don't just happen in 30 days. These are some data from Pennsylvania, which has an all-payer, all-age database. And so this graph shows the blue line is COPD patients, green is diabetes patients, and the red is just all discharges from the hospital. And you can see that a lot of readmissions occur within 30 days, but a lot occur after 30 days. Half or more occur after 30 days. Second is that if you look at why patients are going back to the hospital, in many cases, they're not going back to the hospital for the same thing that they went in for. They are going back in for something else. Again, this is data from Pennsylvania database for COPD patients. And of the patients who had COPD who were readmitted to the hospital within 30 days, a little over a third of them came back in for COPD. Another 20% came in for other lung conditions, pneumonia, et cetera, and a whole bunch came in for something that wasn't even pulmonary. So lots of things going on with these patients that we need to do. A lot of the stuff doesn't even happen at the transition process. So keeping with the spirit of listening to the patient, here's a real live case study. 88-year-old woman, moderate dementia, this is 2010, July 2nd, goes into the hospital for a urinary tract infection that she became septic. Hospital intervened appropriately, gave her IV antibiotics, fluids, she made rapid improvement. But being nice to her, they kept her in the hospital probably a little bit longer than they should have kept her in the hospital. And she deconditioned, couldn't walk well, was sent to rehab to try to get her back into She spent time in the rehab facility, went back to her assisted living facility, and 3 days after she was back home, she ended up going back to the hospital with another urinary tract infection. Hospital said, okay, another urinary tract infection, give her antibiotics, give her fluids, get her back 3 days, send her back to the rehab facility because she's still having even more trouble now walking. In the rehab facility, she develops a UTI. The nurse practitioner in the rehab facility said that their policy was not to treat asymptomatic UTIs. So it progressed a couple more days to the point where she had shaking, chills, and fever and was taken to the hospital with sepsis. Hospitalized again, so first hospitalization, second hospitalization. For the same thing, hospital does the exact same thing. This is sort of, a definition of insanity is sort of doing the same thing over and over again. So hospital, give them antibiotics, etc. Family says she ain't leaving until you do something to stop this from happening again. So finally, the physicians do something that is not something that they think is appropriate, except for somebody who keeps showing up in the hospital, said, okay, we're going to have a prophylactic antibiotic regime. And so now a year has gone by that she has not come back to the hospital. However, after all of this time, she can't walk independently anymore and she's in a wheelchair. Not a good story. None of this was a transition issue. This was an issue of trying to understand what was going on with this patient and what should we really do to get at the root causes of why she was ending up in the hospital. So, what does that say to me? Well, we can't be just thinking about transitions. We have to be thinking about how do we improve the way care is being delivered in these post-acute settings. In rehab. So in rehab, is the job to just rehab you or to also say, so maybe we should be monitoring for your UTI or the other things that you need to be able to live independently. And there are some efforts. Now, again, continuing with the let's create new acronyms, the project Interact, Interventions to Reduce Acute Care Transfers. That was actually a pretty good job with that one, I think. The QIO in Georgia did this, and this is something that CMS has been trying to promote for nursing homes, to think about what nursing homes can do inside the nursing home to be able to prevent people from going back to the hospital.